গেছি?
না, not yet ভাইয়া।
কথা বলা শুরু করুন।
Okay. Good evening, respected and dear physicians. Welcoming all in today's webinar, ECG Basic and Beyond. Today, our topic is bradycardia and cardiac pacing, which will be delivered by our respected Dr. Rafique Ahmed sir. But before going on the usual pattern, today we first discuss on a very sad episode that happened today morning. One of the cardiologists of Bangladesh, Dr. Taposh Bhumi from Tangail, died early in this morning. So we mourn his death. Now I request Professor M. Atahar Ali sir and Dr. Abdul Chowdhury sir to say some words regarding Dr. Taposh sir, and then we start the program. Atahar Ali sir.
স্যার আনমিউট করেন স্যার আপনি। মিউট।
আসলে আমি অত্যন্ত হৃদয় বিদায়ক চিত্তে এবং কি বলবো, খুবই দুঃখ ভারাক্রান্ত মনে আমি তাপসকে স্মরণ করছি। এই জন্য যে তাপসকে আমি চিনতাম এবং আরো জানতাম যে আমাদের ওই যে মুনমুনদের সাথে সে ঘোরাঘুরি করতো। তারপরে আমাদের এই যে আদিত্য আছে, যেটা গণপতি আদিত্য, তাদের আমি যতটুকু জেনেছি আদিত্যদের ক্লাসমেট। আর তাপসের সাথে আমার একটা ইনডিরেক্ট যোগাযোগ ছিল, সে টাঙ্গাইল থেকে প্রায় আমার কাছে রুগী পাঠাতো আর কি, যে জন্য আমি তাপসের নামটা জানি। ওর সাথে ফিজিক্যালি অনেকদিন ধরে আমার কোনো যোগাযোগ নাই, কিন্তু তাপস যে একজন ভালো কার্ডিওলজিস্ট এবং সে যে টাঙ্গাইলে খুবই ভালো সার্ভিস দিত এবং সে পেশেন্টকে একদম প্রপার অ্যাডভাইস দিত। আমার কাছে সে প্রায়, আমি দেখছি যে গড়ে প্রায় 1-2 মাস পর পরে সে একটা করে রুগী এসে আমার নাম লিখে পাঠাতো। তাপসের সাথে আমার এরকম একটা রিলেশন ছিল। এবং মাঝখানে অনেকদিন আগে আমি যখন এনএসিবি 317 নম্বর রুমে ছিলাম, সে একদিন সে এসে আমার সঙ্গে দেখা করে গেল আর কি। তো সে আসলে এই যে গণপতি আদিত্য আছে তাদের ক্লাসমেট আর কি, ওই বয়সেরই। তো তার এই অকাল প্রয়াণটা রিয়েলি খুবই দুঃখজনক। আমি আজকে দুপুরেই শুনছি খবরটা। আমি জানি না কার কপালে কি আছে, কিন্তু রিয়েলি এটা আমরা এই তাপসের বিদেহী আত্মার মাগফিরাত কামনা করি। এবং আমি জানি না যে তার ফ্যামিলি থেকে কেমন আছে, তো সবার পাশে এসে আমরা দাঁড়াতে চাই এবং এটাই হচ্ছে আমাদের তাপস মরুভূমি। আমি এইটুকু বলি। তুষার, তুমি দেখো আর কিছু বলবে কিনা।
স্যার, আমি ওয়াদুদ স্যারকে অনুরোধ করছি প্রফেসর আব্দুল চৌধুরী স্যারকে কিছু বলার জন্য। I request Professor Abdul Chowdhury sir to say something, some words.
He was our student, and he has been serving in Tangail for quite a while, and he was serving there well. He was very popular in there because he always take care in giving the proper advice, proper treatment to the general patients. And today, being a cardiologist, he died of an acute heart attack. This just means that he was actually coming from there to Dhaka for better treatment. He died on the way. This actually shows us that we have to ensure very good and proper treatment in everywhere of this country. Tangail is a district, and at a district level where a medical college is there, if one has to come to Dhaka for proper treatment, that's very unfortunate. In future, we have to have such service so that when we are in trouble, we can get the proper treatment. Our population can get the treatment. That should be our goal. That should be our motto. I'm really sad, and we send our deepest condolences to his family. I don't know about his family that well. I hope somebody can say something about that. And we should be beside the family at this hour of need. Tushar. Firoz, do you want to say something?
আমার মনে হয়
থ্যাংক ইউ স্যার, থ্যাংক ইউ স্যার। তাপসকে আমি চিনি, তাপস এনআইসিবিডি থেকে এমডি করা। তাপস আমার সিনিয়র, আমি দাদা বলতাম ওনাকে, তাপস দা। খুবই ভালো একজন মানুষ ছিলেন, খুবই ডেডিকেটেড স্টুডেন্ট ছিলেন। এবং যেটা স্যার আতাহার স্যার এবং ওয়াদুদ স্যার বললেন যে উনি টাঙ্গাইলে গেলেন এবং টাঙ্গাইলে অ্যাসিস্ট্যান্ট প্রফেসর, কারেন্ট চার্জে অ্যাসিস্ট্যান্ট প্রফেসর ছিলেন এবং খুব ডেডিকেটেড ওয়েতেই ওই এরিয়াতেই উনি প্র্যাকটিস করতেন। মাঝে মাঝে আতাহার স্যার যেরকম বললেন ওরকম মাঝে মাঝে কিছু প্রবলেমেটিক পেশেন্ট পেলে আমাদের কাছে পাঠাতেন, আমার কাছে পাঠাতেন মাঝে মাঝে, এবং আমি মাঝে মাঝে কিছু পেশেন্ট ওনাকে দিতাম, কারণ জানি যে উনি খুব ডিপেন্ডেবল একটা লোক। যেটা ওয়াদুদ স্যার বললেন এটা আমার কাছে সবসময় মনে হয়, এটা আমি সবসময় বলি যে আমাদের এই কার্ডিওলজি সেবাটাকে ঢাকা কেন্দ্রিক বা শহর কেন্দ্রিক না রেখে যত দূর ছড়ানো যায় তত সাধারণ মানুষের জন্য যেমন নিরাপদ, সাধারণ মানুষের সেবার জন্য যেমন নিরাপদ, আমাদের জন্য একইভাবে নিরাপদ। এই যে আমরা এই বিভিন্ন রকম একাডেমিক প্রোগ্রাম করি, এই ইসিজি প্রোগ্রাম, ইকো প্রোগ্রাম, অন্যান্য প্রোগ্রাম করি, এই সবগুলো প্রোগ্রাম আমার মনে হয় এই লক্ষ্যকে উদ্দেশ্য করেই করা, যে দেশের সারা দেশের সব মানুষকে, সব কার্ডিওলজিস্টকে, সব ডাক্তারদেরকে এই কার্ডিওলজির ইমার্জেন্সি সম্পর্কে অ্যাটলিস্ট একটু জ্ঞান দান করা, এদের একটু সতর্ক করা যে এই জিনিসগুলো হলে যেন আমরা সহজেই ব্যবস্থা নিতে পারি। আমরা তাপসদার বিদেহী আত্মার মঙ্গল কামনা করি। উনার স্ত্রী আমি যতদূর জানি একজন ডাক্তার, কিন্তু ছেলে মেয়েদের সম্পর্কে আমি জানি না। আশা করি তারা এই শোক সামনে উঠতে পারবেন।
আমি একটু বলতে চাচ্ছি তাপস দাস সম্পর্কে। আমাদের আসলে 1 বছর পরেই হয়, কিন্তু পরের দিকে আমরা একসাথে হই ওনার থিসিস পার্টের সময় এনআইসিবিটিতে, শেষের দিকে ক্লাসও একসাথে করি। তো আসলে সত্যিকার অর্থে খুবই মর্মান্তিক। উনি 2 দিন যাবৎ কিন্তু ওনার চেস্ট পেন অনুভব করছিল, কিন্তু উনি ওইভাবে জিনিসটা প্রকাশ করেনি বা হসপিটালে ভর্তি হওয়ার জন্য আসলে তখনই যদি ভর্তি হতেন, প্রপনিন আয়োনিক রেইস ছিল যেদিন, কালকে এক্সপায়ার করলো তার আগের দিন আর কি, গতকাল আর কি। আসলে আমি মনে করি উনি আসলে একটু সেলফ নেগলেক্টেড হিসেবেই এটা হয়েছে আর কি। এরপরে যখন প্রচন্ড ব্যথা হয়, এরপরে তার বাসা থেকে টাঙ্গাইল প্র্যাকটিসও করেছে সে কিছুটা ব্যথা নিয়ে। পরে যখনই করতে পারে না, রাত্রি 9টার দিকে সে মির্জাপুর থাকেন, ওনার ওয়াইফও থাকেন মির্জাপুরে। ওনার ওয়াইফও ডাক্তার, ইয়ারমেট আর কি, রংপুর মেডিকেল থেকে পাশ করা মুনমুন ম্যাডামদের ইয়ারমেট, বা গণপতি দা আমাদের এখানকার হেড অফ দ্য ডিপার্টমেন্ট, আতার আলী স্যার যেটা বললেন, তাদের ইয়ারমেট রংপুর মেডিকেলে। চাকরিও বেশি দিন ছিল না, এক বছরের কিছু সময় আছে হয়তো চাকরির, অ্যাসোসিয়েট প্রফেসরের লিস্টেও ছিল ওনার নাম। সেই হিসেবে আসলে পরবর্তীতে ঢাকা যাওয়ার পথেই আসলে মিসহ্যাপটা হয়ে যায় আর কি। তো এটাও খুবই জরুরি একটা ছিল যে সে যদি সাথে সাথে ভর্তি হতো টাঙ্গাইল মেডিকেল কলেজেও প্রথম দিকে, টেক কেয়ার নিত, তাহলে হয়তো এই দুর্ঘটনাটা হয়তো ঘটতো না আর কি। তো যাই হোক, ওনার বিদেহী আত্মার চির শান্তি কামনা করছি। আর ওয়াদুদ স্যার যেটা বললেন, আসলে এভরি কর্নার, এভরি মেডিকেল কলেজে আমাদের ওই সেট আপ থাকা দরকার, থাকলে সবার জন্যই সুবিধা, নট অনলি ডক্টর, প্রত্যেকটা মানুষের জন্যই সেবা যেটা অ্যাকচুয়ালি পাওয়া দরকার আর কি, সেটা যেন আমরা পৌঁছে দিতে পারি, সেটাই আসলে আমাদের মোটো। থ্যাংক ইউ ভেরি মাচ।
আমি একটু অ্যাড করতে চাই ওয়াদুদ এবং গোবিন্দের সাথে। প্রথমে আমি খুব গভীর সমবেদনা জানাচ্ছি ডক্টর তাপসের এই স্যাড ডিমাইসের জন্য এবং তার পরিবারের প্রতি। যেটা আমি অ্যাড করতে চাচ্ছি সেটা হলো যে প্রায়ই রুগী পাই আমরা যে ডিস্ট্রিক্ট লেভেল থেকে, অথবা সেই ডিস্ট্রিক্টে হয়তো মেডিকেল কলেজও আছে, ওখান থেকে রুগীগুলো চলে আসছে, পাঠিয়ে দিচ্ছে ঢাকায়, যে আপনারা ঢাকায় চলে যান হার্ট অ্যাটাকের ইসিজিতে ডায়াগনোসিস হলে, যেটা ওনারা ওখানে অ্যাটলিস্ট স্টেপটোকাইনেজ ইজ অ্যাভেলেবল এভরিওয়্যার, অ্যাটলিস্ট একটা স্টেপটোকাইনেজ শুরু করে দিয়ে অ্যাম্বুলেন্সে দিয়ে একজন যদি সম্ভব হয় একটা ডাক্তার দিয়ে যদি ঢাকায় পাঠায়, তাহলে এই ধরনের ঝামেলাগুলো সম্ভবত হয়তো আমরা এড়াতে পারি, এই ধরনের দুর্ঘটনাগুলো। কেন যেন এই পেরিফেরিতে ইভেন ডিকার্ড করা স্পেশালিস্টও ভয় পায় স্টেপটোকাইনেজ দিতে। আমার মনে হয় যে এই থ্রম্বোলিসিসটা সর্বত্র চালু করা উচিত। তারপরে
জামিল,
কোনো একটা ক্যাথল্যাব কন্টেনিং কোনো একটা হসপিটালে, সেটা ডিস্ট্রিক্ট লেভেলে অনেক জায়গায় ক্যাথল্যাব এখন আছে, পুরানা মেডিকেল কলেজ সবগুলোতে ক্যাথল্যাব আছে, এর যে কোনো একটা নিয়ার বাই একটা হসপিটালে পাঠানো উচিত।
জামিল, আমার মনে হয় যে আমাদের গোবিন্দ যেটা বললো এটা
জি।
আসলে তাপসের বিষয়টা একটু আলাদা এবং ভেরি আনফরচুনেট।
জি জি জি।
2 দিন ধরে সিমটম হওয়ার পরেও সে কোনো ট্রিটমেন্টের
হ্যাঁ,
জানে।
হ্যাঁ।
এটা তো আমরা তো ডাক্তাররা সবসময় নিজেদের নেগলেক্ট করি।
তাপস সম্পর্কে
যেমন-
আমি আরেকটু বলি, সেটা হচ্ছে যে আমি মানে কি বলবো, আমার আস্তে আস্তে মনে পড়ছে মানে হি ওয়াজ ভেরি ভেরি একাডেমিক, কিন্তু
Yeah.
মানে সাংঘাতিক একাডেমিক একটা ছিল। আমি জানি না, সম্ভবত সে বোধহয় এমআরসিবি পার্ট 1 করছিল কিনা জানি না, এরকম সে একাডেমিক একজনই ছিল।
ওনার সাথে আমার সরাসরি কখনো
তো-
সংযোগ হয়নি আর
তো
কি।
যাক, পরবর্তীতে হয়তো বা টাঙ্গাইলে গিয়ে সে খুব ভালো প্র্যাকটিস করতো এবং
হ্যাঁ,
টাঙ্গাইলের
সার্ভিস দিয়েছে প্রচুর।
হ্যাঁ সাংঘাতিক সার্ভিস দিত। এবং লাস্ট অফ অল আমি জানি না, হয়তো বা পেশেন্টের ডিমান্ডেই সে হয়তো বা এরকম অবস্থাতে সে মানে প্র্যাকটিসটা কন্টিনিউ করছে কিনা জানি না। তো এটা আসলে রিয়েলি ভেরি আনফরচুনেট। আর আমার মনে হয় যে সবাই যেটা বললো, ওয়াদুদ ভাই যেটা বললো, এখন এটা আমাদেরই বলার কথা, আমরা স্যার বলবেটা কি, সেটা হচ্ছে যে আসলে প্রত্যেকটা দুইটা যেটা জামিল যেটা বললো সেটা হচ্ছে যে অ্যাওয়ারনেস, যে আসলে এটা করা উচিত। আর ওয়াদুদ ভাই যেটা বললো সেটা হচ্ছে যে এই ফ্যাসিলিটিস থাকা উচিত। এই দাবিগুলো এখন আমাদের সবারই আসলে করার সময় আর কি।
আতার ভাই, আমি একটু কিছু বলবো?
শিওর শিওর, হ্যাঁ। আরে খালিদ মাসুম ভাই জি প্লিজ।
আচ্ছা, ডাক্তার তাপসের সাথে আমার আসলে দেশের বাইরে কয়েকবার ওই বিভিন্ন কনফারেন্সে দেখা হয়েছিল, যে খুব একজন নম্র এবং ভদ্র, এবং সে কনফারেন্স গুলাতে আমি যতটুকু দেখেছি যে শুধু বেড়ানোর জন্য কনফারেন্সে সে কোনো সময় যেত না, সে মনোযোগের সাথে পার্টিসিপেট করত এবং সে খুব মেটিকুলাসলি, মানে যেটা আমাদের যে জ্ঞান আহরণের যে চেষ্টা, এটা আমি তার মধ্যে দেখেছি। আর একটা জিনিস হচ্ছে যে আমাদের এই যে রুগী ট্রান্সপোর্ট করা ঢাকার বাইরে থেকে, আমাদের ট্রান্সপোর্টেশন সিস্টেমটা কিন্তু খুবই খারাপ। আপনারা সবাই জানেন ডক্টর তাসবিরুল ইসলামের কথা, পালমোনোলজিস্ট, এখন উইসকনসিনে আছে। জামিল আর আমার ইন্টার্ন ছিল সে, আর ওয়াদুদের সাথে, ওয়াদুদের 1 বছরের জুনিয়র। তো তার একবার হার্ট অ্যাটাক হয় এবং হি ওয়েন্ট ইনটু ভিএফ, এবং তাকে অ্যাম্বুলেন্সের মধ্যে তাকে ডিফিব্রিলেট করা হয় এবং হি সার্ভাইভড, এবং সে ডিফিব্রিলেট করে তাকে প্রাইমারি পিসিআই করে। এখন সে খুব একটা অ্যাক্টিভ লাইফ লিড করছে। সে আমাদের বিভিন্ন রকম, আমাদের দেশে এই কোভিড সিচুয়েশনেও খুব মানে যথেষ্ট সে তার অবদান রেখেছে। হ্যাঁ, তো আমার মনে হয় যে এই যে ট্রান্সপোর্টেশনের যে এটা আমাদের একটা সামাজিক আন্দোলন হিসেবে আমাদেরকে, আমরা মনে হয় যে আমরা কার্ডিওলজিস্ট এটা একটু নেতৃত্ব দেওয়া, যে রুগীকে সেফলি ট্রান্সপোর্ট করা, যেটা জামিল বলেছে। হ্যাঁ, কারণ আমাদের আসলে পেরিফেরিতে আমরা যতই বলি যে কার্ডিওলজি সার্ভিস প্রোভাইড করা, হ্যাঁ, এখন তো দেখা যাচ্ছে টাঙ্গাইলে হয়তো সেই একমাত্র কার্ডিওলজিস্ট, আর হয়তো বাকিরা তার সবাই তার জুনিয়র। তো যারা অ্যাপেক্সে যারা আছে, তারা যদি কোনো সময় অসুস্থ হয়, তাদের কিন্তু চিকিৎসা পাওয়ার সম্ভাবনাটা অনেকখানি কমে যায়। তো এই জন্য আমাদেরকে একটা আন্দোলন হিসেবে এটা নেওয়া দরকার। আর আমাদের এখানে একটা জিনিস হচ্ছে যে যারা আমরা ইন্টার্নশিপের সময় বিদেশে যেটা নিয়ম হচ্ছে যে বিসিএলএস এবং এসিএলএস কোর্স করে তারপর ইন্টার্নশিপ শুরু করতে হয়। আমাদের দেশে কিন্তু কোনো ইন্টার্ন আমার মনে হয় বিসিএলএস এসিএলএস কোর্স করে ইন্টার্নশিপ শুরু করে না, এবং সিসিইউতে মাত্র 7 দিনের জন্য একজন ইন্টার্নকে প্লেস করা হয়। তো সে তার নিজের পরিবারের লোকজনকেই তো সে চিকিৎসা দিতে পারবে না। হ্যাঁ, তা আমার মনে হয় যে আমাদের এই সামাজিক আন্দোলন হিসেবে এই জিনিসগুলোকে আমাদের একটু, আমার মনে হয়, চিন্তা ভাবনা করা দরকার। এবং আইপিডিআই এর পক্ষ থেকেও আমার মনে হয় যে এটার একটা আমার মনে হয় যে একটা উদ্যোগ নেওয়া দরকার, এবং তার ফ্যামিলির আমরা একটু খোঁজ খবর নিয়ে, যে তারকে যদি মোরাল সাপোর্ট তো দিতেই হবে, প্লাস যদি তার কোনো আর্থিক সহায়তা তার ফ্যামিলিকে করার যদি কোনো সুযোগ থাকে, আমার মনে হয় এটাও আমার মনে হয় আমাদের একটু এক্সপ্লোর করা উচিত।
কথা বলবো
স্যার স্যার
জি স্যার।
মানে লাইফের দুইটা জিনিস আছে, হোয়াট ক্যান হ্যাপেন এন্ড হোয়াট ইজ অ্যাভেলেবল। বাংলাদেশে মানে খালিদ মহসিন যেটা বললো যে অ্যাম্বুলেন্সে ডিফিব্রিলেট করা হয়েছে আমেরিকাতে, এটা এক্সেলেন্ট, এন্ড ওইটা আমরা আন্দোলন করতে পারি 5 বছর পরে। ইউ ক্যান অলসো ম্যাটেরিয়ালাইজ দ্যাট, বাট হোয়াট আর ইউ গোইং টু ডু ইন দ্য নেক্সট 5 ইয়ার্স? আমি জামিলের কথাটা আমি যেটা বলতে যাচ্ছি সেটা হলো কি, 1 নাম্বার, streptokinase thrombolytics is widely available, or if it is not widely available, it can be made available anywhere in Bangladesh. আমেরিকাতে একটা প্রোটোকল আছে যে যখন কোন একটা রোগীর অ্যাকিউট এমআই হয়, পেরিফেরাল কোন ডাক্তার যদি একটা ইসিজি করে দেখে অ্যাকিউট এমআই, আমাদের কাছে এটা ফ্যাক্স করে। আমরা তখন ক্যালকুলেট করি যে ক্যান দ্য পেশেন্ট রিচ এ ক্যাথ ল্যাব উইদিন 90 মিনিটস। If they cannot reach within 90 minutes, then we recommend that they should be given thrombolytics. It is a very simple protocol যেটা বাংলাদেশে এখনই এটা ইমপ্লিমেন্ট করা সম্ভব কালকে সকালবেলাতেই। And it is true also for any third world country including Nepal and India. Second, আরেকটা জিনিস যেটা তোমরা এবং আপনারা সবাই করতে পারেন, it will be very, very nice যে you create a call schedule. Call schedule কি হবে যেটা আমাদের আছে, যে আমরা একজন ডাক্তার everyday on call. And anybody can reach us. There is a reaching modality. এটা যে সাধারণ দুনিয়া সবাইকে দিয়ে দেবো তা না, কিন্তু ডাক্তাররা জানবে যে এই ডাক্তারের সঙ্গে আমি এই দিন কনসাল্ট করতে পারবো। এখন মনে করলাম যে ময়মনসিংহে একটা রোগীর একটা প্রবলেম হয়েছে। So there is a problem somewhere in Mymensingh, and he calls Dr. Wadud Chowdhury. Wadud says that, okay, send me the ECG, and it is very simple to send it by a text. And then he can say, well, listen, just give thrombolytics. I know the physician in Mymensingh knows the treatment, but reinforcing from somebody from Dhaka or is always helpful. Even it cannot be from Dhaka. Maybe in Mymensingh there are 2 cardiologists, and I'm a little confused what to do, and I can send it to my colleague, and he says, give thrombolytics. We are reinforcing. So this actually you should think as a society, cardiac society, or the cardiology community, that Dhaka-based cardiology is fantastic. It is as good as anywhere in the world in Bangladesh. Kintu periphery is nice. So the peripheral cardiologists, if they can reach peripheral primary care specialists, medicine specialists, if they can reach the cardiologists, the problem of Bangladesh, and of course I'll give you a political background. I was talking to somebody from Calcutta, and he's a cardiologist in India, and now a practicing cardiologist in Bangladesh, in America. He says patients in Kolkata dislikes cardiologists in Calcutta. Why? They are not reachable. They go to Bombay. Same complaint comes from patients in Bangladesh. So everybody is looking for somebody else. But the question is, availability is important. One of my friends died in Rajshahi Medical College. He was a retired army major, physician. He had an acute MI, and he was in Rajshahi Medical College. On telemetry monitor, nothing being done. And he died exactly on day 3 when he is supposed to die of ventricular arrhythmia. If somebody made a phone call to Dhaka, he could have been transferred to Dhaka, he could have got an angioplasty. So I think, yes, we are talking about knowledge, technology, and everything, but I think one of the conversations that you all need to do is to make this, whatever is available in Bangladesh, available to us. Remember, we may criticize Bangladesh's healthcare as much as we want to, but Bangladesh actually has one of the best healthcare in the world. I'm not comparing with United States, I'm not comparing with United Kingdom or Germany, but compare with Thailand, compare with Cambodia, compare with Sub-Saharan Africa. We have one of the best healthcare in the world. And what we need to have a conversation is to make it available and the communication. So please do that. And I think as a society, if you could do it, that would be great. Availability of this knowledge. And just one phone call, text, and other advantage Bangladesh has as one of the best communication system in the world. Internet availability, cell phone availability is available in the villages. A village doctor can do an ECG and text it to a cardiologist in Dhaka. It will do 2 things. One, it will do patient care. Secondly, it will spread your goodwill. It will also be good for your business because you will get more patients. All right.
Thank you, sir.
Thank you, sir.
Thank you, sir.
I think I'm a little delayed today. Shall we get started?
Yes, sir. Right.
স্যার আমার মনে হয় আমরা শুরু করতে পারি।
Okay. But my lecture today will not be very long. We'll talk about pacemaker indications. I mean, most of it is well known. I'm going to go over the major features and recent changes, and recent change, not much of a change, but change of mindset. So pacemaker indication classification, and this classification is this is more for the junior doctors. It is universally accepted for any modality of treatment. That means class 1 indication means that any modality of treatment, there is scientific evidence and there is general agreement amongst physicians that this treatment modality is beneficial and not harmful for the patient. Class 2 indication, there is divergence in opinion, but in class 2A, the weight of evidence and opinion is mostly in favor. So if we ask 10 physicians and look at literature, there is enough evidence that this is beneficial. And class 2B, yes, there is beneficial, but not well established, but we all believe that this is helpful. And class 3, this is also a very important part, that this modality of treatment is unnecessary and can be harmful for the patient. And I think this can be applied for pacemaker. This can be applied for use of a beta blocker. Or we can talk about, we are just talking about thrombolytics. It can apply for thrombolytics also. Please remember this classification of any indication or modality of therapy. So, ASA guidelines. So there are a few highlights. And this is interesting that in 2018, they highlighted this issue that nocturnal bradycardia should prompt screening for sleep apnea, but itself is not an indication for permanent pacemaker implantation. So they felt it's so important that they put it in one of the 10 highlights. This is not only a problem for Bangladesh, it is also a problem for us. We see it all the time. In Bangladesh, you see it less because there is less telemetry monitor, but we see it more. So this is important that if somebody has nocturnal bradycardia, then it should prompt screening for sleep apnea, but it is not an indication for permanent pacemaker. Second, sinus node dysfunction, there is no established minimum heart rate. This is important. Everybody asks me, what is low heart rate? Or there is no established pause duration where permanent pacemaker is indicated. But we have to establish the relation between symptom and the bradycardia. That is important. So if somebody has a pause of 4 seconds during sleep and no symptom, that's one way. Another indication is somebody has a pause of 2.5 seconds and at the same time had an episode of dizziness during daytime. That becomes an indication for pacemaker. So I think that temporal relationship is something that we need to establish. What else? And they changed this one, that acquired second degree AV block, high grade AV block, complete heart block, not due to reversible cause. This is permanent pacemaker indicated regardless of symptom. In the past, they used to say, well, they have to be symptomatic. But no, it doesn't matter. If somebody has mobile to AV block, high grade AV block, complete heart block, and it is not due to reversible cause. For the junior doctors, reversible cause will be, let's say, somebody comes with inferior myocardial infarction and has developed complete heart block. That most likely is a reversible cause. Or somebody, some other cause, anything that is reversible. Second, other thing that has changed is that if the LV ejection fraction is 36 to 50%, and there is AV block which needs permanent pacemaker, and we think that the patient will pace in the ventricle more than 40%, then the preferred mode of pacing should be biventricular pacing or his bundle pacing. Because as soon as I put the right ventricular lead, it will cause AV dysynchrony, ventricular dysynchrony, and the EF will worsen and the patient may become symptomatic. We don't go up to 50%. I think nowadays, this is actually an underused modality, but I think it should be done. The problem is that once we put a permanent pacemaker, a dual chamber in a patient with ejection fraction of 45%, we don't know which way the patient will go. Some patient will do very well. The other thing I do is that I sometimes will do septal pacing. That is a little bit better than just doing RV pacing. Sinus node dysfunction. There are reversible causes of, sorry, I'm going to go to the, So there are sinus node dysfunction. I think when we talk about sinus node dysfunction, we need to look at the reversible causes. One is acute myocardial ischemia, or in fact, athletic training can cause sinus node dysfunction. That's not pathological, that's physiological. Atrial fibrillation is a cause. That what happens that somebody has borderline sinus node dysfunction, develops atrial fibrillation with cardiovert. That patient can be bradycardic for a few days. It doesn't mean that patient will need a pacemaker. Eventually, their heart rate can come back. Cardiac surgery. This is common occurrence, valve replacement, MAGE procedure, bypass. There can be some bradycardia for a few days, and that is not an indication for pacemaker. Drugs or toxin, cocaine, organophosphate, those kind of things can cause it. Bradycardia, these are reversible. Electrolyte, we looked at ECG of hyperkalemia, that can cause bradycardia, but that is not an indication for permanent pacemaker. Sometimes what we will do, somebody comes with renal dysfunction and has marked bradycardia with heart rate of 30, we'll put a temporary pacemaker in until this thing resolves. Hypervagotonia, hypothyroidism is one cause that we should do. I mean, if somebody comes with marked symptomatic sinus bradycardia, we should make sure the patient is not hypothyroid. Hypovolemic shock can sometimes cause bradycardia. And then hypoxemia, hypercapnia, sleep apnea, those kind of things can cause bradycardia. The other thing is infection. I put Lyme disease at the back because Lyme disease is not present in Bangladesh, but we have typhoid, we have malaria, dengue, viral hemorrhagic fever, Guillain-Barré, all these things can cause bradycardia, and they should be treated. So if somebody has fever and bradycardia, that's kind of unusual, because they should be tachycardic. But these are reversible causes and treatable causes. The other thing is medication. These are reversible beta blockers. I'm sorry, spelling is wrong. Calcium channel blocker, and there is another medicine called psychiatric medication. Lithium can cause sinus node dysfunction. Lithium is not much reversible. It can become permanent. So what is the definition of sinus node dysfunction? That's with symptoms. Sinus bradycardia less than 50 beats per minute. Ectopic atrial bradycardia rate less than 50 beats per minute. Sinoatrial exit block. Sinus pause more than 3 seconds. Sinus arrest. Tachybrady. We always get asked, what is tachybrady? That means sometimes patient is bradycardic, alternating with atrial tachycardia, atrial flutter, or atrial fibrillation. Please remember, once the patient develops permanent atrial fibrillation, they no longer fall into the category of sick sinus node dysfunction or sick sinus syndrome. And then chronotropic incompetence, inability of heart rate to increase to meet the demand of the body. By definition, if it fails to achieve more than 80%, sorry, this is wrong, of age predict, that is called chronotropic. But we have to make sure that we correlate with symptom. This is a very difficult feature to prove. And then isorhythmic as AV dissociation. This is one of the features of sinus node dysfunction. What can happen that somebody has marked sinus bradycardia and at the same time there is junctional rhythm. So there can be some AV dissociation without heart block. So these are the features, but of all these things, please remember, this must be correlated with symptom. If somebody has ectopic atrial bradycardia, heart rate of 49 beats per minute, has absolutely no symptom, that doesn't require any intervention or treatment, especially pacemaker. Occasional sinoatrial block without any symptom, a nighttime sinus pause of more than 3 seconds really doesn't matter. What is important? These features must be correlated with symptom before we decide to put a pacemaker in. Now, class 1 indication for symptom in patients with sick sinus node dysfunction, symptom directly attributable to sinus node dysfunction, which most of the time is difficult. Because what happens, most of our patients come with symptom and we find evidence of sinus node dysfunction, we put pacemakers in. And the patient who develops symptomatic bradycardia as a consequence of therapy, of which there is no alternate. An example will be, let's say I have a patient with cardiomyopathy, ejection fraction of 40% or 45%. I give carvedilol maximum dose, which he needs, and I don't think I should stop that. and the heart rate becomes 39 beats per minute, and he is fatigued or she is fatigued. That will be a class 1. This is a new addition as a class 1. But we have to make sure there is no alternate to that. Now, how can we prove that somebody has class 1 indication with symptoms? So this is one of our patients from 1993. Patient was having disease spell. I gave the patient the event monitor, and in the event monitor, he put a marker here, and then we retrieved the ECG. As you can see, as the moment he became dizzy, he had a pause of more than 3 seconds. And that is what's happened, that we have made it into a class 1 indication. And before that, you can see there are pauses. I didn't measure the timing, but looks like probably SA block, and then there is a sinus arrest here with a pause. So this is a class 1 indication for permanent pacemaker implantation, and he did not have any reversible cause. So this is another patient that, I'm going to bring this ECG, presented to hospital after an episode of syncope. And when the patient came to the emergency room, heart rate was 29 beats per minute, and he was not on any medication to cause his bradycardia. I mean, this is clearly a condition, and you can see that is actually, it looked like junctional, but there is a P wave here with a short PR. It's probably ectopic atrial rhythm with a heart rate of 29. So clearly sick sinus syndrome with underlying bundle band block. And class 2 indication, we believe, if we believe that the symptom is due to sinus node dysfunction, and we have symptomatic chronotropic incompetence. An example will be this patient. This is actually one of my patients that had, this is a relatively young person, 50-year-old male with history of syncope and wearing a Holter monitor, and he woke up from sleep with a nightmare, feeling dizzy and diaphoretic, and a pause of 21 seconds. This was most likely, this was the cause of his symptom. There was no daytime pause. And this didn't look like sleep apnea, because sleep apnea, this is unlikely that you will have such a big pause. And then when he woke up, he was dizzy. He reported that. So this was basically almost class 1, but I think we consider it as a class 2 indication. And there is another patient that, this patient came with syncope, and during telemetry monitor, patient will go into atrial fibrillation and then convert with a pause. And you can see there are 2 conversion pauses, even though the patient was asymptomatic at this time, because patient was sleeping in the morning, early morning, lying in bed, but came with syncope and had other features of bradycardia and tachycardia, and we felt that this is probably a class 2 indication for permanent pacemaker implantation. This is not an asymptomatic patient with pause. Class 2B indication, this is something that they added, that if somebody comes with bradycardia, has fatigue or other symptom, non-specific symptom, and we feel that this is probably sinus node dysfunction, but we are not sure. And then they recommend that you can give a trial of theophylline to see if the heart rate increases and symptom improves. Then at that point, you can make a decision to put a permanent pacemaker in. I have never used this modality, but I think it's an interesting concept to use, that if somebody, relatively young person, comes with borderline bradycardia and you think that the patient is symptomatic, give theophylline with the improvement of symptom, then may consider permanent pacemaker to help his symptom. Class 3 indication, that means we should not put pacemaker in asymptomatic sinus node dysfunction. I'm saying sinus node dysfunction, basically asymptomatic sinus bradycardia. Example will be this patient, heart rate of 40 beats per minute, 82-year-old male, has no symptom at all. This patient should not get pacemaker. I'm not going to go through this slide. These are all they are important. So bradycardia, the nighttime bradycardia is not an indication for permanent pacemaker implantation. Again, to re-emphasize, bradycardia or even short pause during sleep is not an indication for pacer. And other thing is that whenever we see a pause or bradycardia in Holter monitor, we have to make sure that it correlates with symptom before we use it as an indication for permanent pacemaker. This is an example of one of our patients. The patient was wearing, she is a 54-year-old female, no history of syncope or pre-syncope. She was having frequent episode of atrial fibrillation, and we gave her a cardiac monitor for 30 days. for management of atrial fibrillation. And you can see that the pause of 4.3 seconds with 2 non-conducted P waves. So it can be defined as intermittent high-grade AV block. Question is whether she should get a pacemaker or not. So first of all, the time was 3:24 a.m. Now, I could not just make an assumption that she was sleeping because I had a similar patient with a long pause on cardiac monitor. And I called the patient. I said, what were you doing at 5 o'clock in the morning? And she said, Dr. Ahmed, I work at night and I passed out. So it is important that just because it happened at night does not mean that the patient was sleeping, because some people work at night. This patient I called, she was sleeping at night and she had no symptom. The other feature that you look at, if you look at carefully, that you can see that this P2P interval is gradually getting longer. That is, patient is developing sinus bradycardia along with heart block and then became tachycardic. So basically, this is very much consistent with high vagal tone, because high vagal tone, what it will do, it will slow down the sinus node, can also cause heart block. And of course, I called the patient and had no symptoms. So this patient does not need pacemaker, clearly. So there are a few other things that, with heart block, class 1 indication, acquired second degree, Mobis type 2, high grade or third degree AV block without any reversible cause is a class 1 indication for pacemaker. Neuromuscular disorder with conduction disorder, such as second degree heart block, complete heart block, this is of course an indication here, but HV interval of more than 70 milliseconds during cardiac electrophysiology study, they should get a permanent pacemaker. Permanent atrial fibrillation with symptomatic bradycardia. Basically, patients have developed heart block. And symptomatic AV block due to therapy for which there is no alternate. Like an example will be that I have patients who get beta blocker with atrial fibrillation. If we stop beta blocker, they become extremely tachycardic. We give them small dose of beta blocker, they become extremely bradycardic, almost like complete heart block. Those are the patients that should get permanent pacemaker without stopping the medicine. And there are a few other conditions, infiltrative cardiomyopathy, sarcoidosis, amyloidosis, with Mobis 2 AV block, high grade, they should be considered for pacemaker with or without defibrillator. Like if somebody has cardiac sarcoidosis, we would put defibrillator. Cardiac amyloidosis, probably just pacemaker. It's interesting that the more MRI we are doing nowadays, we are identifying more of these cases. It's like anything that when we were medical students, we never saw myocardial infarction. Everybody had peptic ulcer perforation and died within 24 hours. And I can guarantee you that all those patients who had acute myocardial infarction dying and then when you have the modality of treatment, you find these cases. There is another issue that patient with first degree AV block or Mobis type 1 AV block, is it an indication for pacemaker? Sometimes it can be type 2B. Recently, I had a patient who had Mobis type 1 AV block, went for an intervention. Interventional cardiologist said, look, patient developed 2-to-1 heart block on the table without any medicine. We just didn't believe. Then we did an EP study. Sure, we found that there is significant AV conduction problem with prolonged HV. But if we want to put pacemakers in this patient, you have to carefully prove their relationship with the symptom. I will not take lightly to put a pacemaker in patient with Wenckebach AV block unless I can prove that there. One of the way to do it is to put them on a treadmill. If you put them on a treadmill and their AV conduction improves, that patient doesn't decide. A lot of times you will see that as soon as they walk on the treadmill, they will have higher grade AV block. Then they may need a pacemaker. Class 3 indication, that means we should not put pacemaker in asymptomatic first degree AV block, asymptomatic type 1, and other thing is that AV block is likely to resolve. In America, there is a common, in Maryland, where I live, Lyme disease is a common problem. And what we do, anybody young coming with complete heart block, we will definitely do a Lyme titer to make sure they don't have Lyme disease, because Lyme disease, once you give antibiotic, their symptom improves. Now, bifascicular and trifascicular, they have changed the criteria that if they have syncope, bundle branch block with HV interval more than 70 milliseconds, they should get a permanent pacemaker. and then alternating bundle branch block, patient should get permanent pacemaker irrespective of symptoms. It's interesting. This is a patient that is one of our patients that in October 25th, you see that IVCD of left bundle type. And then this is October to same day, develops right bundle branch block. So, and left anterofascicular block, PR interval is borderline prolonged. So basically bifascicular block. Look at what happened to this patient next day. Same day, later on, developed complete heart block. So to the extent that we had to put a temporary pacemaker in this patient. So that proves that patients who alternate between right bundle, left bundle, they're at higher risk of, so if somebody has both right and left bundle, they should be considered for permanent pacemaker implantation. Class 3 indication, asymptomatic fascicular block without AV block. That means if somebody has first degree AV block, right bundle, left anterofascicular block, no symptom at all, we should not put pacemaker. I have a patient who I've been following for more than 15 years. And he has first degree block, PR interval of 260 millisecond, right bundle branch from left anterofascicular block. Has no problem at all. We actually did the EP study, age interval was normal, and we decided to wait. And 15 years later, he's still fine. It's not that I'm discounting it totally, but symptom is very, very important. We should not put pacemaker in unless patients have symptom. Neurocardiac syncope is a group that is very difficult to assess. One of these is a cardio inhibitory. You all know these things. It can be cardio inhibitory or vasodepressor. I'm not going to go over it, or mixed. So what will be the indication? Recurrent syncope. And then if we do EP study and we do cardiac stimulation, if there is a pause of more than 3 seconds, then we should consider. But you have to be careful that some of these patients, normal people, can also have pause with carotid sinus massage. So this is not something that we routinely use. If you feel that patient has recurrent syncope and you think clinically that it is probably due to carotid sinus hypersensitivity, then only you should put pacemaker in this patient. And then class 2A indication, recurrent syncope without clear provocative events and with a hypersensitive cardioinhibitory response. And neurocardiac syncope can be an indication. The problem with neurocardiac syncope is that you put a pacemaker in, they have two components. One is bradycardia, one is hypotension. So if I put a pacemaker in a patient with neurocardiac syncope, I have to have proof of significant bradycardia or asystole, and still I will warn the patient that, look, your symptom may not resolve completely. So this is an example of a patient. This is our patient. This is from 1995. She was a long distance runner, 24-year recurrent syncope. We put her on a tiltable test. Within 3 minutes, she develops a systole of 30 seconds. Now we have a problem because this is a young female. They don't want a scar on their body. And this was 1995. We at that time did not put pacemaker in this patient, but today probably we will consider the patient. One of the things is that I can consider pacemaker, or I will probably put a loop recorder in to prove that her clinical symptom is also with this pause. And some of these patients will benefit from pacemaker. Over the last 30 years, I have put 5 or 6 pacemaker for this condition, but those are carefully selected. This patient did not get a pacemaker. I had a patient when I was in Augusta, Georgia. She would get syncope every time she would get any medical procedure. First of all, she will get pass out when she will see any needle or IV line insertion. Then she would even have syncope talking about medical procedure, going to doctor's office. She would say, get so vagal, and that patient would put a permanent pacemaker in. I'm going to skip that. So I think that's about the highlights of these things. And if there is any question, I'll take it.
Congenital, please a little bit elaboration on that.
Which one?
Congenital complete heart block.
Oh, yes. I did not touch that part because I going over it, I realized that these topics are becoming so broad and big that in one congenital complete heart block, what we do, we follow these patients. One problem is that a 5-year-old child, if you put a permanent pacemaker, you have to put many. As they grow older, the lead stretches. In a very young person, sometimes they have significant bradycardia and stunted growth. And if we can prove that's due to low heart rate, we have to put pacemaker in very, very young children, even though that's not my specialty. But in general, we should wait, try to wait. And if they have no growth problem, if they have no symptom, we should keep following them. And then what we do, we keep looking at their heart muscle function and the size. If there is any cardiac dilatation, that means that there is a problem. And that will be a time that to consider permanent pacemaker. The other thing is the discrepancy between the ventricular rate and the sinus rate. And recently I saw a patient who was 60-year-old, and she has done extremely well. And I put her on a treadmill. She could only walk for 3 minutes. And her sinus rate went up to 150, ventricular rate went up to only 70. And that would be a patient that, even though she said she's asymptomatic, she actually is not. And she should go to a pacemaker. So with congenital heart block, we like to wait as much as possible. Thank you.
Sir, I've got a question.
Hello, sir.
Yes.
Sir,
Hello, Firoz.
we do not put pacemaker in bradycardia patients, asymptomatic bradycardia patients. Does that mean that this pacemaker has got no mortality benefit in patients who are asymptomatic?
It's interesting. Pacemaker has never been shown to have mortality benefit, unfortunately, because first of all, in 6NS syndrome, even if you don't put pacemakers, the worst case scenario will be they will pass out. Unless they're driving, they're not going to kill themselves or swimming. So there is no mortality benefit of pacemaker. Complete heart block, nobody has done a randomized study. I'm sure if we do a randomized study with complete heart block patients, we may be able to show mortality. Yes.
There will be no study because I think in general, people will think that this is unethical to randomize these patients.
Oh, yes, no question about it. Complete heart block, you cannot. And 6NS syndrome, it is more of a quality of life issue than anything else. And
the asymptomatic bradycardia, the issue is that what is the natural history? The asymptomatic bradycardia patients' natural history, if there is no underlying organic heart disease, structural heart disease, their prognosis is generally good. But I think as cardiologists, we are obligated to look for the further into the asymptomatic bradycardia. If there is some, for example, somebody with asymptomatic bradycardia has aortic stenosis, then these patients have worse prognosis over time. So we are obligated to investigate them. Rafique, I have a question for you. So yes. This sleep apnea and then pauses.
Yes.
বাংলায় বলি আমার তো ভয় লাগে মনে হয় যে তোমাদের পানে চাইয়া বন্ধু আর আমি জাগিব না No, so we get panic. And yes. EP guys, I have talked to several EP guys for several patients, and you don't budge. Asymptomatic bradycardia pause in the night during sleep apnea, you don't say I need a pacemaker. Why? When you will you need a pacemaker?
What? We have a very, very high threshold for this. Because it's like this, that it's a dangerous driver in Bangladesh driving in Chittagong hill tracks. So we are like that with sleep apnea, and justifiably. If you can prove they have symptoms, then only you should put a pacemaker in. And I think if you treat sleep apnea, then this improves significantly. Please remember, these people can also have pause during daytime.
Yep.
But every time they have daytime pause, I talk to the patients because these are big people, 200, 300, 400 pound people. They're sleeping during daytime also. So the fact that this is daytime does not mean they were not sleeping. But we will not put pacemakers in. The problem we face is somebody comes with syncope, and we think that is vasovagal syncope, and has a sleep apnea. Then we are kind of stuck, but still we try to resist. If you talk to all the EP doctors, I'm sure your EP doctor will do the same thing. Say, look, this is not the cause of the syncope.
But Rafique, what is the issue that when there is a long distance truck driver and you see this, it's a nerve wracking. I don't want to be his cardiologist.
That's very true. That's very true.
I don't know, Dr. Maski, you understood my my Bangla quote. I don't know how to translate that into English.
No, he understands Bangla.
Must understand
No,
Bangla.
that phrase I did not understand.
Sir,
I understand everything, but that quote I did not understand.
I remember Khaled Mohsin said something very, very interesting the other day. He said, I'm happy to treat my patient, but I don't feel good when I put a pacemaker in and the patient comes back with recurrent syncope.
Exactly.
What it means that my initial diagnosis was not correct.
Yeah.
I treated something different. Maybe he has some other cause of syncope and I just put a pacemaker because I found a little bit of bradycardia or something that is not related to the symptoms. I think that's why we should try to do as much as possible to correlate symptom with the bradycardia or use best judgment. Please remember, we talk to each other a lot. I mean, I've been in practice for more than 30 years. I have colleagues who are young doctors, but they're young relative to me, 15 years. We talk to each other all the time. And then sometimes we say, look, maybe we should put a pacemaker in.
Sir, I have a question, sir.
Yes.
Hello, sir.
Yes.
Sir, I have a question. Sir, after MI, there is a group of the patient. The patient had got that transient AV block, 2nd degree or 3rd degree, but the AV block does not persist, but the patient have the bundle branch block, particularly right bundle branch block. That is transient AV block followed by the persistent right bundle block. What should be this type of the patient, this category?
Yeah, but Atahar, if it is inferior myocardial infarction and if it improves, I don't think we need to do anything at all. If it is anterior myocardial infarction, then most of them are actually permanent. If they improve, I mean, the worst case scenario, what I will do, I'll probably study the conduction system to see if there is any conduction. Because if you have done a, let's say somebody comes to the hospital and you have done an angioplasty within 30 minutes, just like you have saved the myocardium, you have also saved the conduction system. That doesn't need pacemaker. So I think we should just evaluate those patients and look at that, best study the conduction system.
Rafique sir.
Yeah.
Rafique sir, I have just your opinion about a scenario. Suppose a patient with anterior myocardial infarction develops complete heart block. He is revascularized, but his LV function doesn't improve that much. So in this group of patients, should we wait for 40 days to decide about whether to put a pacemaker or an ICD, or we can put a pacemaker straight away in this group of patients?
So, did this patient get intervention?
Yeah, intervention, but because of the late, the timing was not optimum. So the patient LV remains about around 30, 35 or something like that. So
Okay. So I'll go back. So let's take a patient who has acute myocardial infarction, and you did an intervention. Ejection fraction is 30%.
With a complete heart block, yeah.
30%? No.
30.
I'm just making up another scenario. Ejection fraction 30% and no heart block. So what I have to do, I have to wait for 90 days before I put a defibrillator in. Now, if somebody has normal left ventricular function, you have done an intervention, patient is in complete heart block, and you should put a permanent pacemaker in. If now this patient, same patient, has AV dysfunction, conduction, complete heart block, ejection fraction of 30%, current guideline is that if the patient has the indication for pacemaker, and they should get a pacemaker defibrillator combination. And that is acceptable indication at the moment. However, you will have to consider biventricular defibrillator because patient has LV dysfunction also with underlying heart block, either 2-to-1 or complete heart block. So your patient with ejection fraction 30% post-intervention with heart block, expected to face more than 40% in right ventricle, should get a biventricular defibrillator.
It's one of the newer indications. Yeah.
Yes.
Sir, if the QRS complex is narrow, even then we should consider for biventricular?
Well, because this patient has complete heart block or high-grade AV block. So expect that the wording is, if you expect that the RV will pace more than 40%.
Yes.
if more than 40% of the time RP, it can happen also. Let's take a patient, same patient with atrial fibrillation with marked bradycardia. And you expect that the ventricle will pace more than 40%. That will get a biventricular pacemaker, a defibrillator.
I have a question, sir.
Yes.
In
Very
case of
well said. Can I just add one point?
Yes.
So if আপনার যে scenario গুলা, the scenarios you gave, the LV function is less than 35, revascularized, patient not in complete heart block, but we try guidelines directed therapy and then reassess by the CMS rule 90 days, but the original trial was dynamite with the 40 days that they did not see any benefit. We are now giving wearable life jacket, like a life vest, and then see whether we buy time. In the ischemic cardiomyopathy group, what is your take on the ischemic versus non-ischemic? I am more in favor of giving to the ischemic. In the non-ischemic group, where the EF is less than 35, with the Danish trial, I'm very reluctant to give life vest, and there are insurance issues. What is your take on this?
Well, I mean, this is this is an American legal system issue. If I have a choice, if I had no legal issue, I will not give life vest for the non-ischemic cardiomyopathy patient. You are absolutely right. But unfortunately, in a litigious society, that's very tough to do. And we give life vest to everybody while we're waiting. We wait for both group 90 days. I feel that if somebody with non-ischemic cardiomyopathy, we can probably wait longer before we decide to put ICD in this group of patients.
Sir, I have got another.
Sure.
The common scenario is we get patients with history of syncope. At the present, he has got bifascicular, trifascicular block. And according to you, we should correlate. We should have a temporal relation between these two events. But in our country, with 24 hours Holter monitoring, frequently we cannot establish this relation. What should be our approach?
Oh no, if somebody has syncope and has first degree AV block, right bundle, left anterofascicular block, there is universal acceptance that you can put permanent pacemaker in that group of patients, provided you have no clinical suspicion of anything else.
Yes.
Let's say somebody was totally dehydrated or septic in the setting of a sepsis, passed out. But if you clinically feel that there is no other cause of syncope and patient has a trifascicular block, then you should put permanent pacemaker in. It becomes a little more tricky when it is, let's say, somebody with left bundle bunch block and syncope. A lot of those patients, depending on the age, if somebody is 85-year-old and I feel that probably this is intermittent heart block, we will put pacemaker, and that is acceptable. If it is a younger person, we'll do EP study to look at the HV interval. If the HV interval is long, we'll put a pacemaker in. If the HV interval is less than 70 milliseconds, we'll not put pacemaker in.
So the question is, which are you going to advocate for either of this group, the 85-year-old group and the 50-year-old group?
I have a question, sir. We have seen the so many elderly people complete heart block for 4 years or 5 years, just mildly symptomatic or barely symptomatic, and having pre-syncope. And in that case, patient did not agree to put pacemaker, or when referred to improvement in the concept of further consultation, and did not agree. And in that group patient, can we give the to increase the heart rate propenthelin or any other treatment modalities, or how can we deal in those group of people, elderly people, a heart rate around 40, 45?
Yeah. Question is, somebody with complete heart block with a ventricular escape rate of 40 beats per minute. Those drugs are not going to work there. They will work in the AV node or the sinus node. So that's not going to be helpful at all. And as we discussed earlier, your patient proves a point, and there are many patients, probably in Bangladesh, with complete heart block who has lived for many years without a pacemaker. So
So another question: after putting a pacemaker, origin in ischemic origin, use of beta blocker. After putting pacemaker, use of beta blocker regarding this issue.
If somebody has permanent pacemaker, and they should be treated like anybody else. If they have clinical reason to use beta blocker, of course you can use beta blocker. There's no problem with that.
Thank you.
Question: let's say an 85-year-old occasional Beximco or one syncopal episode, and I'm suspecting intermittent complete heart block. And as can who is 50-year-old, similar presentation.
Yes.
And considering the financial situation, can we advocate for say intermittent complete heart block, single chamber pacemaker, VVI pacemaker for them?
Well, I mean, sure. I mean, symptom-wise, if somebody has intermittent heart block, and we have single chamber, will be as good as anything else for those patients. Those patients are not going to pace a lot.
Yeah.
They may have. I mean, let's say somebody with left bundle, normal conduction, and during telemetry monitoring, you find 3-second pause with complete heart block, and you put a permanent pacemaker in that patient, they will do fine for many, many years to come. It will prevent their syncope. And then in future, if it happens that they develop complete heart block pacing all the time, and you feel that there is a significant symptom related to just single chamber pacing, then you can upgrade it to dual chamber. It makes perfect sense in Bangladesh.
Sir,
Yes.
Query: in a patient with in a atrial sensing ventricular pacing mode, if the patient develops inappropriate tachycardia, so what will be the option of treatment? Actually, would you like to reprogram the pacemaker, or we can use ivabradine in this situation to reduce the sinus rate in this group of patients?
Oh yeah. So I have patients with heart failure who has biventricular pacemaker and tachycardic. In those groups, first of all, you should use beta blocker. Maximize the dose beta blocker. I'm assuming that you have maximized beta blocker. So if somebody has heart failure, I can use metoprolol succinate or carvedilol to decrease the heart rate. And if after that it does not improve, ivabradine is a good drug. I have a couple of patients where I've used ivabradine.
Sir, I have a question, sir.
Yes.
Sir, I am Dr. Khundukar Asaduজ্জামান, sir.
Yes, hi.
Sir, just 1 week back, one of my patient attended to my OPD chamber. He had history of CBG 1 month back, and he came to me with ECG evidence of severe junctional bradycardia with RBB and some episodes of dizzy spell, but there is no history of syncope or pre-syncope. What could be the approach of this patient, sir?
Well, I'm sure the question is, it was not heart block, just junctional bradycardia.
Yes, sir.
So this finding is, what was the heart rate?
Around 37 or 38.
Yeah, so this patient basically is sick sinus syndrome patient, and the patient will need beta blocker. You cannot, because patient has coronary artery disease, the patient needs permanent pacemaker. No question about it. He has all the symptoms. He has dizziness. So it will be a class 2A indication. Yeah.
Yes, he is symptomatic.
We can
Excuse me for a second.
Professor Hasan sir has got some ECGs. Professor Hasan sir, should I share the screen?
Okay. You have the screen, EKGs.
Yes,
Let me see whether, can you see my screen now?
Yes, sir. We can see you. See your screen.
All right. So I just wanted to touch base one thing from the beta blocker. So I don't know, Rafique bhai is there or not. The patients with the significant coronary disease and LVEF less than 35%, and then chronotropic incompetence or bradycardia where you really want to give beta blocker, then the question will come in that whether you will give them ICD with BIV pace or not, with the BIV ICD. But I wanted to tell you one thing, that patients with LV function preserved, the beta blocker role is questionable. We actually did a publication, and that was like one of the top 10 of the week, was that when there is in the era of reperfusion, if the EF is preserved, the beta blocker benefit is not that much that you think that it is. So something to think about, that don't be obsessed with beta blocker for coronary disease if the EF is normal. So I don't know whether you can see this EKG. This is from just a couple of days ago, actually November 4th, if you can look at. I request you just...
Can you share the slide, please?
Oh, you can't see the slide?
Yes, we can see the ECG, but...
Slideshow mode.
Yeah, it is slideshow mode, believe it or not, but it is from a photo. So you will be struggling a little bit, but let me point out that there is...
This is a photo from monitor?
What's that?
Is a computer monitor is photo from? This ECG photo is from a computer monitor.
However, we can see it.
Yeah,
Let me see if I can
better.
Yes, better.
big.
Yes, better.
Better, right.
I think you can read it.
No. Now it is very good.
So this is actually how old is this guy? He's 46-year-old and coming with chest pain, and STEMI was activated. And then the patient has this EKG, and what do you want to do? The ER doctor activated the EKG, STEMI.
Now
What are the symptoms, sir?
Chest pain.
Chest pain.
Okay.
Like maybe
Good thing that I took the name of the patient away, so it is not a problem. Okay.
now,
Yeah.
the echo findings, troponin and echo findings.
what was the echo?
Okay, so first of all, when there is STEMI activation in the US, we have this problem of dot to balloon. So he has been in the ER about 25 minutes already, okay? And then I have to decide whether this is truly a STEMI and should I take to the cath lab. And the ER doctors did not tell me much. On the way to the hospital, I asked the nurse that, does he have any other problem? And the nurse says he has a history of COVID about 7 days ago. And now does not have fever, but has chest pain.
This patient actually has a left ventricular hypertrophy with strain, and it's my assumption it can be a very likely to be a case of hypertrophic cardiomyopathy.
Most likely.
Okay, and then ER doctor is saying there is ST elevations in the precordial lead B1, B2, and then biphasic T wave. So he's saying there is active ischemia going on, regardless whether you call it, this a STEMI or not. He should go to the cath lab.
Yes.
And do you want to know anything about this patient? Khalid Mohsin said hypertrophic cardiomyopathy. Anything else? Anyone?
Any history of sudden death in the family?
No. But I tell you, one of the common thing I ask is this patient hypertensive? Remember, hypertrophic cardiomyopathy is familial hypertrophic cardiomyopathy in the absence of increased afterload. That means there should not be any AS, there should not be any hypertension. This EKG can be present, and we have a large cohort of patients with end-stage renal disease and left ventricular hypertrophy with uncontrolled hypertension. And we have a population with cocaine. So this patient is not renal disease and did not have any problem with cocaine or anything. And then,
I have one question.
As this patient has got the chest pain, that is the ischemic type of chest pain, and this is the ECG. Whether you will wait for the troponin or you will bring the patient to the cath lab?
If we wait for the troponin, two problems will happen. That I will have to wait and I lose the dot to balloon. So we will not fulfill the dot to, in case it is a true problem. And then I would not get paid either. Because if I miss the 90 minutes, by the hospital rule, I'm not going to get paid.
I have one question, sir. It's very important in the patient.
In emergency, whether in STEMI patient, STEMI activation, bedside echo, whether it is routinely done before STEMI call?
Okay, so I don't use the term routine, but I don't think that doing echo ever delays the process of STEMI triage. And I tell this to the fellows that echo, bedside echo available now, that you can call the echo tech to get this, but that makes the delay. And if the echo tech is not in-house, but there in most of the hospitals, there is bedside echo available. So you can have a look. What do you want to look for?
Sir, actually this ECG does not fulfill the criteria of STMI.
Okay, who is this?
This ECG and chest pain, if it is not a STEMI, it can be a non-ST elevation.
Definitely.
Might be due to severe aortic stenosis or
it needs a cap. But in acute stenosis, it will not present with acute ischemia.
So I think we all agree that we need to look for the cause of hypertrophy, and it is possible that there is familial hypertrophic cardiomyopathy. How about the question of Dr. Atahar Ali? He is saying the patient is having chest pain.
At least we can compare with the previous ECG if the patient does have previous ECG. At least
has LVH and there is some T inversion, but not like this deep T inversions, but some strange changes there as well. But Atahar Ali is saying the patient is having chest pain. What to do?
I like to add that hypertrophic cardiomyopathy patients have often chest pain that simulates ischemic cardiac pain.
Yes.
And that is due to relative ischemia. It's not due to coronary artery disease.
Yeah.
So these patients have chest pain and that get relieved by taking rest, sometimes with nitrates, but some nitrates may aggravate the chest pain.
Yeah, so
Jamil, but it is that the symptom is like the acute coronary symptom, not the it is the acute coronary.
I dealt with several patients with hypertrophic cardiomyopathy with acute chest pain, but even I did 1 or 2 coronary angiograms; those were normal.
Yeah.
With
So in this patient, there was some T wave changes and some biphasic T wave, but biphasic T wave valence can be not so sensitive in LVH. But in this case, to answer Atahar Ali's questions, what I did, I deactivated the STEMI and then followed the troponin, did the cath, and it was a myocardial bridge of the LAD that we found. So it all fits in together: familial hypertrophic cardiomyopathy and then a myocardial bridge. So
excellent.
In the ECG, there is a triple T sign. The T is inverted in 1 and 2, and it is upright in 3. This also favors hypertrophic cardiomyopathy.
Yes, absolutely.
Please highlight the point.
A triple T sign.
Triple T sign.
Triple T.
Yeah. 1 and 2 inversion, 3 upright.
Right.
Yes. And this feature was first described by General Aniswais.
Yes.
And his name is in the ECG book written by.
Actually, I don't know that General Aniswais' name is there, but when I was a fellow, it was pointed out that this is a good sign to know. Usually, you don't see that in the aortic stenosis related LVH. You don't see that. So I did not know that one of our eminent cardiologists was involved in this.
Yes.
Nice to know. Okay, so, and actually my class friend's dad. I'll tell her. So another important case, this is specifically for the EP cardiologist. 22-year-old coming to our hospital with trauma, multiple gunshot injury. Okay, and then vitals you are looking at the vitals. Blood pressure 240 over 128. It's a 22-year-old. And then this EKG. He was tachycardic and this EKG. Oh, but excellent. Rafique bhai is back.
Yes.
সময় মতো আসছেন স্যারকে ব্যাকগ্রাউন্ডটা বলে দেন একটু
Yeah, I saw it. I heard the news. Yes.
alternating
I did not know what the hell is this. So I gave beta blocker, Rafique bhai, and the blood pressure was uncontrolled. I gave beta blocker like metoprolol, several doses, and then I got an echo.
Now, before that, we want to know the ECG diagnosis, sir. Is there any evidence of the sinus node activity, sir, in V1? Can you see the P wave, sir?
I don't think so.
No, it's difficult to say. If there is a P wave, it is buried in the QRS complex.
In AVL with the ST elevation or fast complex, that looks like a P
But
wave.
there is no P wave, Firoz.
Let me tell you that what problem we had, because we had a war with this EKG among our EP guys, literally physical war. And one of the fellow pointed out, adding to the further pain, how about AVL? Is this ST elevation? And one of the third year fellow told the first year fellow, shut up, we are having problem. So I just
I mean, the heart rate is 120, right?
Yeah.
I mean, okay, two possibilities. One, there is a sinus rhythm, which P wave we cannot see with ventricular bigeminy. The other thing that I would think of, bidirectional ventricular tachycardia.
Right, sir.
Okay, Rafique bhai, beautiful, beautiful. I thought it is bidirectional VT, but I was shot down by the EP guys. One EP guy said this is sinus tach bigeminy. I said no, I don't see any P wave. And then he was walking me through the P wave, which I thought he's saying that this is the P wave.
Right, right. What I wanted to say.
I don't know whether this is convincing, but it is possible. But this is,
One second, sir. Which one is the POF, sir?
Look at the
can
view
you see my,
over at the line, straight line there, the small.
In V1, there is a some.
No. Listen, we can imagine P wave, but the imagination must be substantiated by other means. That means we have to see something similar in other leads. Here, there is nothing to compare with.
Yeah.
So, yes, it's a possibility sinus rhythm with bigeminy, but I will consider bidirectional VT because that exactly looks.
So the cause of bidirectional VT is catecholamine
Yes.
induced like polymorphic VT, right?
Most likely.
Yes, catecholaminergic.
Yeah. So
Polymorphic
this is
ventricular tachycardia.
and this is the echo. So I don't have all the full study, but look at the basal part moving much better than the whole apical, anteroapical septal wall. So this to me looked like the apical ballooning type with high catecholamine state. So,
Yes, cardiomyopathy, yeah.
any comment?
Yeah,
So,
yes.
to cut this story short, this patient was treated with beta blocker and all that, and about day 8, the LV function normalized. I had another patient, which is actually works in my department. He came in with Takasubu picture, and then we blood pressure little uncontrolled, and everything good, LV function normalized. And then he had a surge of hypertension about a year later. I did a belly pain, I did a CT, adrenal mass, pheochromocytoma, which I missed in the first time. And so high catecholamine state. And we are now learning from the COVID time, high cytokine level, cytokine storm, adrenaline storm, all these can give the stunning of the myocardium. And hold your breath, follow up the patient, and then they will come back. This is a 69-year-old, came in with history of fall. And this is the vitals in the emergency room. And this is the EKG.
Why did he fall?
I have no idea.
Well, fall doesn't mean anything. Well, did he trip? So this is the reason I'm asking this question, that as a doctor, it's my job to ask, why did the patient fall? I always ask them that, number one, did you pass out? But old people cannot tell that they passed out because they don't know they passed out. I ask them then, could you see yourself falling down? And they said, no, I could not see myself. I was standing, next thing I know, I am on the ground. So that's important.
In England, they differentiate very nicely, like a drop attack or syncope. In US, we try to stick to the definition that there is transient loss of consciousness with full neurologic recovery and no evidence of neurological deficit, and then we need a witness if possible.
So that's why Abid, that's why it's kind of important that it says that patient denies syncope but had a fall. If we put this together, I have to clarify why the patient fell down.
Right. But what I'm saying, Rafique bhai, in this case, the patient was brought in by the EMS, and after a fall, there was nobody to say, and patient doesn't remember. I'm just giving you.
Okay, that's important. If the patient does not remember why he fell down,
yes,
that means he passed out.
That is syncope.
That's syncope.
But I think the history is very important. But after this EKG, we accepted that this is syncope.
Oh no.
Yep.
He cannot pass out from this. All right. What is this? Okay, no, we need to bring one of the junior doctors who is attending from the audience for this ECG. Can we do that, Atahar?
Yes, sir.
Yeah.
Ribu.
Yes, sir.
Hello, Ribu.
Yes, sir. Yes, sir.
Any of the attendees who are interested, raise your hand.
Before that, Govindo can participate. Govindo.
রেহান কে ইনভাইট করা যেতে পারে স্যার
Yes,
Rehan.
Dr.
Dr.
Rehan.
Rehan. Okay, I'm making him panelist, sir.
রেহান
Yes, sir. I have made him panelist, sir. He can talk now. Dr. Rehan can talk now.
He's in the screen. Bring him in the screen.
আসছে স্যার
Yes, sir.
I'm giving the heart rate. The heart rate is 300,
or
166
or
beats
even
per
Dr.
minute.
Kamal Hussain, Ovi, or Rehan, anyone.
Okay, sir. I'm bringing Dr. Kamal Hussain Obi also.
ডক্টর রেহান
Yes, sir.
Sir.
And do you want to comment on it?
Ovi or Rehan?
Sir. Assalamualaikum, sir.
They're both here, sir. They can talk. Yes, sir.
As a video, open your video, please.
Video লাগবে না, comment করুন।
Sir, ECG showing, sir, white complex tachycardia, sir. Sir, most likely, sir, ventricular tachycardia, sir.
You describe the morphology, and can you
Morphology of PRX.
what should
Yes.
where can be the origin of the VT?
Inferior lead axis, concordance or discordance.
Sir, here, sir, concordant, sir. Here, sir, QRS complex, sir, B1, B2, B3, B4, sir, concordant, sir.
Dr. Rehan,
morphology
Dr. Rehan,
এই পর্যন্ত উপরের দিকে V4 থেকে V6
V1, V2, V3 positive, V6, V5.
Sorry. A concordant discordant কথাটা I want to clarify to the juniors. Look at the sharp part of the complexes. That's
sir, in V1 side RBB morphology, sir. Most likely, sir.
And V4 to V6, the sharp apex is looking downwards, so it's not concordant.
Downward.
Okay, let me. In his defense, V4 is negative, V5 is negative, V6 is negative.
Yeah.
Lead V1 and V2, you can always argue this is the QRS complex, this is the QRS. So it looks kind of negative. However, if you look at lead V3, it is very clear it is positive.
Yes.
Positive. Yes.
So, when you look at the lead V2, it's tough to say which one is QRS, but this is the positive part of the QRS because in lead, so V3 is not negative, so it doesn't fulfill the concordance criteria. So anytime you look at an ECG, look at lead by lead, and I appreciate that you were thinking of that term concordance, but just carefully look if all of them are negative, then it is concordance, or all of them positive.
And I want to also tell the very juniors, whenever we say concordant or discordant, we mean the chest leads. Look at it.
Ovi can add some point. Ovi?
Sir, Assalamu alaikum, sir.
Wallace, hello, Ovi, you can add some point.
Sir, the ECG showing that there is a wide QRS complex is wide, and there is a P wave absent, and rate is
166,
and there is a ventricular concordance. Chest lead is, sir, all negative or not?
No, just discharge. There is no concordance, neither positive nor negative concordance. That's because V1 is positive, V6 is negative, so does not fulfill the concordance criteria.
নিচের দিকে তাকাচ্ছে, তাই না? তাহলে concordant কোথায় হলো? Concordant মানে হলো from V1 to V6, there will be all the complex will be looking in the same direction. এখানে
according to sir Bogota criteria, sir. So according to sir Bogota criteria, sir, there is a first point is absent of RS complex in V1.
Good.
The first point.
Yes.
Then we should go through the second point. R2S distance more than 100 millisecond. Then the last point, sir, morphology, sir. Morphologically, sir.
Okay. Who is speaking?
Sir, Dr. Rehan, sir.
Dr. Rehan. Okay. So let's go point by point. You said Brugada thing. What was it?
Sir, first, sir, it is the absence of RS complex in V1.
Is there absence of RS complex in V1? No. Sir, just 1 second. Don't interfere him.
Sir, almost all complexes are RS present, sir. RS present, sir. RS complex present, sir.
Okay.
Then we should go to the second point.
No, please slow down.
Yes, sir.
In Bangladesh, when I was a medical student, we would just memorize and learn and then argue about it. So go point by point. So first of all, you decide which is the QRS complex in V1. It is very ugly QRS complex.
Yes, sir.
And I'm making an assumption the whole positive thing is the QRS complex. So it's just an R wave. So your Brugada thing doesn't fulfill. What was the next thing you said?
So next thing, sir, R2S distance.
And where are you measuring it?
So measuring, sir, it is.
Which lead can you measure? Okay. Which lead has R and S both?
Sir.
Yes,
sir, V2, sir.
Let him speak.
Sir, V2,
which
sir.
One? Which lead?
V2, sir. V2 lead, okay. Sir.
Fine. All right. So you think lead V2, and where is the R wave? That's tiny positive R wave, which is the S wave. In lead 2, V2, the ECG is so confusing. that even
Yes, sir.
for me, it is very difficult to say which is R, which is S.
Yes, sir.
So, but one lead you can look at. Look at lead V4.
Before, yes, sir.
Maybe, you know this dark line, the second line from the dark line from the left is on a positive wave. And maybe that is a small R wave. If that is true, then if you measure from the beginning of that to the deepest point of S wave, it's about 120 milliseconds. What I am to tell you, Dr. Rehan, is that theory is important, but then you apply it to the current picture. So maybe that's a possibility. So what do you think is the diagnosis?
So ventricular tachycardia, sir.
So ventricular, this white QRS tachycardia, unless proven otherwise, is ventricular tachycardia. It does not fulfill any of those algorithms that we have learned so far. But one thing is true. If we look at lead V1, lead 1, it looks like left bundle.
Yes, sir.
If we look at lead V1, it looks like right bundle.
Exactly.
So it doesn't fulfill any of the SVT criteria for bundle branch block. So even if we forget all algorithm, if I see this ECG in the emergency room, my one diagnosis I have is ventricular tachycardia. Unfortunately, it does not, unless somebody has any other comment, this doesn't fall into any of our algorithm of
This
ventricular tachycardia.
comment, Rafique bhai, last comment you made is the most wonderful comment. If it does not follow anything, it is not quite written that way in the book, but I find it very helpful. And another thing, that the deep QS in the V6 in the goes in favor of VT.
Yes.
And then the depolarization, early depolarization time is long. So that means there is muscle to muscle conduction.
Yes. Okay, good. So Hafiz, what happened?
Sir, can I add something?
Yes.
Look at V4. There is a notch in the downslope. They suggest this could be scar-related fatigue.
Yes, exactly. So
okay, so Wadud is going to the next level, like where it is coming from and what to do with this. So this patient lost pulse, CPR initiated and all that, and this is the post-resuscitation.
Mamma mia.
Okay.
Any comment?
I'm not sure about the P waves.
PWave is present here, sir. Sinus rhythm, LBB morphology, white complex, complete LBB morphology, sinus rhythm.
V1 does not fulfill the LBO criteria.
It's almost like a bifascicular block type of morphology, actually. Bi or trifascicular block.
But the question is that, Mohsin, if you commit to left bundle, then you commit to left bundle. Then you cannot go any further, right? I would not invoke, if I am saying left bundle, then I would not invoke bifascicular.
I say something?
Yeah, Rafique bhai.
Okay. First of all, I do not see a P wave.
Yeah.
Number one. Number two, in a very sick patient, the heart rate is less than 60.
Yes.
It has a bundle branch block, which is not a right bundle, which is not left bundle. It is just a ventricular rhythm. So it's a
So is it idioventricular rhythm?
Idioventricular rhythm.
So how can you explain the morpho in lead 1 and
Yes,
and
if you look at lead 1, it looks like left bundle, right?
Yes.
But if you look at lead V6, it does not look like left bundle.
It's
so it is, yeah. So it is coming from the ventricle, but it is not any of those right bundle or left bundle pattern, because there is no P wave. It is not a junctional rhythm. If it was a junctional rhythm, it would fulfill one of the criteria, either right bundle or left bundle, but it doesn't. That's my thinking. Hafiz, any comment?
So some of us looking at the
I think
V1
the P wave is there.
explain and then say it is artifact. Okay, so now this is the EKG after. So this is so important, Rafique, by what you just said, that in a sick patient, when we resuscitate, the immediate post rhythm, don't read too much into this. And I tell the fellows that this patient should be tachycardic. But amazingly, this patient is struggling in 50s. But anyway, this was further. And then ultimately we did the workup. And this patient has a non-ischemic dilated cardiomyopathy. And the question is, should we go for what Wadud was saying, that should we go for any ablation or not? Anybody for that?
জি বন্ধ করে দিয়েছি জি 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 এখন যেহেতু চেস্ট পেইন না আমি আস্তে আস্তে ওষুধ কমাতে যাচ্ছি যেহেতু আমরা অ্যাঞ্জিওগ্রাম দেখে গেছি
আসাদ মিউট কেন
প্লিজ মিউট
Hafiz bhai, it fulfills the criteria of ICD.
Yes.
Yes, of course it is. Patient is getting ICD, but the question is, and that's what we did, ICD, and we did not go for any ablation for now. But if there is a recurrence of VT shock, then something to think about in future.
Right, exactly.
HLM, Hafiz bhai, if the patient gets recurrent shock from the ICD, then radiofrequency ablation should be considered.
Yes. Yeah.
Can I ask a question?
Sir.
So this patient gets an ICD, 1 year later, develops an episode of VT, which is terminated by antitachycardia pacing or one shock. Will you do an ablation on that patient?
No. No, sir.
And
no,
why?
Sir. As it's not that much frequent. If it is very frequent, then
Exactly.
ablation should be considered.
That is the issue. The issue is that if somebody gets one shock a year or one therapy, I don't think we should ablate.
Yes,
if somebody is getting frequent episode. And the other thing we have to remember that non-ischemic cardiomyopathy, it is not scar related. They're very difficult to ablate. So we may have to also consider antiarrhythmic treatment before we send this patient for ablation.
Yes, sir.
And this is my last case, a 41-year-old with familial dilated cardiomyopathy, and then came in with this EKG strip. I have only these two. So if you ask me to go back and forth, I'll go back and forth. This is the 12 lead EKG, and there you capture these white complexes as we acquire the EKGs, and then this is the rhythm strip.
He was put on the ICD before, is it?
Yes, I think it's she is loaded. Loaded means she has ICD.
So that's paced rhythm we are seeing.
No, this is VT.
Looks like in this one is the short run VT, and previous on throughout there was VT. This is all through VT.
Abis bhai, this is VT. Any doubt?
No doubt. But I'm just saying that what to do next, because I was thinking in terms of what Wadud says in the last case, that okay, VT. So what's next? She has ICD. She's on this. Let me show you the medications. She's on Coreg, Entresto, Aldactone, Maltec.
She's getting the lot.
Why is this patient on Maltec?
Rafique bhai, I did not agree. so 41 years.
What is the preparation for Maltec?
This morning I was thinking. This morning I was thinking that I'm going to put this case adding, and when I see this, I said, you probably would be asking me the questions. So this patient, young, and they don't want to see amiodarone toxicity. Don't kill the messenger. I did not put the patient on Maltec, but let me tell you what is the thinking. The amiodarone toxicity.
What is Maltec?
Oh, sorry. Dronidone.
Okay.
So that was the thinking of the cardiologist who continued the patient on Maltec, and then that is the way she came into us.
So this is a problem, because what happens is patients who have recurrent ventricular tachycardia, and we put them on amiodarone, the nightmare scenario is you develop slow ventricular tachycardia like this patient with a heart rate around its cycle length of 480 milliseconds, so probably 120 or so. So you cannot program the ICD that low.
Yeah.
What do you do with these patients? If they are not having frequent VT, stop the medicine, let the tachycardia become faster so that ICD can take care of it. And after that, if it is recurrent VT frequent, then ablation is a thing to do for this kind of patients.
Yeah, so we did, Rafique bhai, and the ATP program was like in 150s, you know. So what I did, I stopped the Maltec, I optimized the beta blocker as much as we can, and then I actually referred this. Further inquiring, this patient's sister had a cardiac transplant, and then she has familial dilated cardiomyopathy. So I'm in touch with the heart transplant center in San Diego to evaluate this patient for that. In the meantime, if there is a recurrence of VT, we can do the ablation, but we are trying to get a cardiac MR and see where is the substrate.
All right.
That's what I have for today.
Thank you very much.
Excellent, sir. Thank you, sir.
Thank you, sir.
Atahar bhai, ये तिनते बोलবেন?
Firoz.
Sir.
ECG of the week.
For the ECG of the week.
By the way, I was actually, when you were discussing, I was watching CNN headlines. Biden is now projected the president.
Oh, good.
No, you know what I want? I don't want Trump to leave the White House. Because I want to see him being dragged out of the White House. And
there are many trolls in the internet. I saw some of them.
Yes. That's what I want to see.
There was a nice troll that people said that we want the president to change, but we want the first lady to remain the same.
No.
Sir, binodon নষ্ট হয়ে যাবে স্যার।
By the way,
is there Dr. Ani Sawal? Is there Dr. Ani Sawal?
Mrs. Jill will be one of the most qualified first ladies. She's a PhD holder.
Sir, this is the ECG?
Yeah, this is the ECG.
This is the ECG. I think just for 1 minute, Govindo.
5-year-old male presented with chest pain.
Govindo.
Ji sir.
How many findings you can see in this ECG?
Okay, sir. I like to say. There is no visible POF, and
there are, Govinda.
There are
a lot of POFs.
There are a lot of POFs.
You are not in the field of BT.
Seems to be junctional rhythm.
Govindo, AV dissociation, P and QRS.
AV dissociation, junctional rhythm is okay. ST elevation, yeah.
Inferior MI posterior with pericarditis.
Yes, acute MI, ST elevation MI.
Yeah.
ST elevation lead 3 and lead 2 as well. And also there is a Z point elevation seems to be in the lead V4, V5.
Yes.
Khalid bhai.
V2 to V5.
Why do you consider
And
pericarditis?
Lead 2, 3.
AVR দেখে মনে হয় pericarditis.
1, 2, 3 AVR.
এবং upward ST elevation in precordial lead.
So Govindo, finally, what are the points? AV dissociation, inferior MI, then what else?
Inferior MI with
you already described J point elevation.
Yes, J point elevation. Yes. So complication, the pericarditis might be MI with pericarditis.
Or MI with early repolarization, like this, na?
Yes.
Actually, যদি আমরা consider করি rate around 75 per minute, more or less regular, but there is no PQRS association. It seems to be related. P going on its own and QRS going on its own.
Yes.
In lead 2, 3 AVF, but I don't see any reciprocal change in 1 AVF. And in the chest leads, we find there's a tall R and upright T wave in V2, maybe in association with inferior, there may be posterior extension, but there is concavity upwards ST elevation from V2 to V6 with a J point sharp notch. They suggest this could be early repolarization. And as there is AV dissociation with, but the QRS complex narrow, so the escapism is from junction. So the diagnosis could be acute ST elevated inferior MI with possible posterior extension, with complete heart block, with junction escape rhythm, with early repolarization.
Regarding TOF, tall TOF, can we say? Can you tell?
Yeah.
TOF more than ROF height.
কিন্তু AVR is supporting pericarditis.
AVR যদি আমরা pericarditis পুরোই করতে চাই, তার PR segment change আসতে হবে. The PR segment is not suggestive. That's the point. Deep clearly because the is associated.
Wadud, I just want to make one comment.
Yeah.
You know somebody by the company it keeps. A early report, এত কিছু ঝামেলার ভিতরে এই EKG তে I will keep that in the differential, but I would not invoke early report because এই অনেক খারাপ সংস্রবে আছে. Not a lot of things going on here. So the explanation for the tall peak T wave, we need to think about, the Shamrock says this acute coronary insufficiency in the LAD territory is separate pathology or not. It may be another separate pathology. We need to keep that in mind. And then, of course, this patient inferior MI recent, is the patient in shock, renal failure, hyperkalemia. Think about that as well. And what Khaled Soban is saying is important, that you also think about in maybe an old patient, I don't know how old, whether there is a transmural pericarditis is happening or not. So a lot of things. This is a very concerning EKG.
Yeah.
Maybe it's
Really.
acute MI, but anterior MI is hyperacute.
It could be. That's supposed
Definitely tall T here.
You are right.
Yes, that suggests that this is may not be the hyperacute. You are not supposed to get that notch at the junction. That notch actually goes in favor of early repolation rather than acute anterior MI as well.
I totally agree with you, Wadud, but in a situation like this, it will be little better to keep that differential down the list, not top on the list.
Can I say something about this?
Yes, sir.
Okay. So patient with inferior ST elevation, complete heart block. So no question, that is acute MI. The problem is, we had a similar case that now acute MI, we have to give heparin if we want to. And now we have ST elevation in V3, V4, V5, V6. And even though we are discussing all these issues, how do you know this is not pericarditis? So I give heparin to this patient and patient develops pericardial effusion.
Yes.
So the management is an issue in this patient.
Yes.
So we had a similar case. What we did is we did an echo, and echo did not show any wall motion abnormalities. Still, we were not very happy. We did an angiogram, came back with normal. That patient did not have complete heart block. So management-wise, I think for all of us, we need to remember that issue of heparin, issue of pericarditis has to be entertained. And I think Hasu will probably agree that one of the quick solution will be to do an angiogram on this patient and be done with.
And another thing is that my question is why there was not a reciprocal changes. The thing is, look at the ST elevation in lead 2 and lead 3. Lead 2 ST elevation is higher than ST elevation in lead 3. That suggests this is LCX involvement. And that also goes in favor that this could be posterior extension could be there. And then the reciprocal change is more likely if the RCA is involved. And the reciprocal change best seen in AVL. Maybe lead 1, but mostly in AVL. And most RCA involvement.
Marriott describes this LCX versus RCA. I think practically this is not a big debate to think about. The point is that when there is a reciprocal changes and you flip the EKG, you see the ST depression in the precordial leads and it has to be proportionate, then you raise the suspicion of infero-posterior extension. But here, uniquely, you see that it goes all the way to like, I don't see the V5, V6, all the way. So it doesn't look like infero-posterior extension. Looks like to me there is a separate explanation to be given for the precordial changes. So I don't know, but there is no question this patient needs to go to the cath lab. One thing I wanted to say, and it is very important, if you do an echo and you see no wall motion in this patient, be aware of VSD and be aware of any significant MR. Because what happens if there is a mechanical complication, the heart tries to recruit everything and you get a false thing by a quick a bedside echo. Oh, EF good. It should not be fooled. You need to keep that in mind that this may be in bigger trouble, particularly if this patient is hypotensive or in pulmonary edema. That means something major catastrophe happening.
And that point you have been raising, that to say that there is posterior extension, there should have been ST depression, that should have been present. But here, all the curved ST elevation, the concavity upwards ST elevation, and with the junction notch, that present all through from V2 to V6. That's why I'm invoking that could this be the coexisting early repolation as well, rather than acute anterior hyperacute state as well. But this is a very complex, very interesting ECG. That's why it's been given.
So regarding early repolarization, the changes rarely is beyond V4.
Not necessarily. You can get in everywhere. No, that's not like that.
But sometimes V5, V6 maybe. Not necessarily.
Not necessarily. There's nothing said like that.
And then, but look, I don't have the AVL, but lead 1 AVL complete sparing in early repol is unusual.
Yes, sir.
And I don't see that striking thing in lead 1 AVL. So
Yeah, that is interesting.
I'm still not in favor of early repol as a first diagnosis, but we need to see, do you have any previous EKG or anything?
No, but I can tell the history of the patient. Actually, that patient later on, we find out that he has acute inferior MI, and there was only early repolarization. There was no posterior involvement. There is possible, but there was no posterior involvement.
Only inferior MI, sir. Means RCA involvement only.
Not necessarily. The it was circumflex involvement. Look at this. Remember that epidural supply mostly from 60%, mostly from RCA, but sometimes could be L6 as well. But it was actually only inferior MI. It's an old ECG, but I remember the patient.
With complete heart block, sir.
Complete heart block.
Firoz.
So, one thing I tell you, one thing that if you see this kind of EKG with precordial leads confusing, I tell the patient to.
If possible, previous ECG. Hafiz Bhai is gone, right?
Actually, to take the previous ECG is very much difficult, sir. This issue first, how tropics are said, very important. Whether you give TPA or streptokinase or heparin during PCI, first issue to rule out the pericarditis or pericardial effusion. Second is two things, always better to include in a single diagnosis. This is the rule in medicine. Inferior MI sometimes may be associated with LAD involvement and anterior MI, because inferior MI produce hypotension that reduces the flow to the LAD, producing anterior MI as well.
Sometimes
there is double
type 4 LAD causes the inferior and anterior MI, both all MI. LAD type 3 or 4.
Is it possible that the 1 AVL had ST elevation initially as a part of early repol?
Can I interrupt the discussion, please? Can I interrupt discussion, please?
Yes, sir.
I think what happens, we are all experienced cardiologists. When we discuss all these complex things, it's good for us. For the junior doctor, it gets confusing. So I think we should keep the message very simple for them, so that we give them the key points so that they understand the key points. This patient has acute inferior MI with complete heart block. And what will be the basic management, just as we are talking in the beginning, what to do in Mymensingh, what to do in Sohitpur. That's very, very important also. So let's keep it simple.
Thank you, sir.
I give you an analogy to explain this, what Rafique Bhai said, analogy. So if we are reading CTA of the coronaries and I see high-grade stenosis is one place, I don't look at the other coronaries that much strictly, because what we are trying to do here is to explain the precordial changes. The CTA read, I said patient needs cath. That means that one area is already putting us in a state to go for the cath, then figure it out. But importantly, if this patient is in shock, hypotensive, I would request everyone to do a echo on the way to the cath lab, because if possible, because you go to the cath lab, but always good to get an idea with the echo. It is like a stethoscope to understand what's going on with the patient. You maybe don't be surprised in the cath lab. Go to the cath lab in a predictable way.
Thank you, sir. Thank you. We are 11:15. I think we should finish the session today. And thank you, Rafique Ahmed sir and Professor Chowdhury Hassan sir. May I request Atahar sir to wrap up the program?
I think I am very much happy to thank our participants for whom this program, and thanks because although the program is too long, but still they are with us, our participants. Thank you. Thanks all the participants for being with us, and all the panelists for active participation today's discussion, particularly Khalid Mohsin, Gobindo, Asaduzzaman, Jamil, all the panelists. And I also happy to thanks Chowdhury, Abdul Wadud Chowdhury for showing such a good ECG and initiating excellent discussion regarding this ECG. But finally, we should remember the final comment of Rafique Ahmed sir. What is the message? So although we initiated the discussion, but we will finally remember the message of Rafique sir. And I also like to thank Chowdhury Hafiz Bhai. Today's ECGs and discussion was very, very excellent. I must congratulate you for this today's session. And we must, this is also, we must thanks our Rafique sir that we have this, that is many of my confusions is clear today, as because sir shows some of the important issues regarding the pacemaker indication. And thanks Beximco for helping all the session on all the days. Rivu and others Beximco participants. So Firoz, thank you very much. You are the last person to receive the thanks. You are the moderator, and I think
thank you, sir. It's
an excellent announcement, sir. The next Saturday, it is Dr. Abdul Jamil. Our audience will be the children, not the adult. That is the children. That is the ECG of the Dr. Abdul Jamil. Next Saturday.
What is the topic next week?
Sir, ECG of the normal and abnormal.
Normal and abnormal in children.
Oh my God, that's a difficult topic.
Yes, sir. I'm puzzled. Eat the lecture.
We should invite some pediatric cardiologists.
We object vehemently.
Can you ask Dr. Fatima, Nurullah Fatima?
Firoz, Firoz, তুমি একটু মনে রেখো যে we should invite some of our pediatric cardiologists, Wadud bhai, Nurullah Fatima, Abdul Salam, Abdullah Shariar, we should invite, and
I'll be asking them all.
Then they should be the panelists in our next session.
Yeah. Thank you, everybody.
Thank you, sir. We have learned a lot.
Good night.
Thank you, sir.
Thank you,
Assalamu alaikum.
Chowdhury, Awesome, sir. Rafique Ahmed, sir. Atahar Ali, sir. Wadud, sir.
পাঞ্জাবিটা ভালো হইছে।
পাঞ্জাবি না এটা, গেঞ্জি।
Kamal Hossein Obi, thank you very much.
Thank you, sir.
Thank you, moderator.
Thank you, sir.
Obi Rehan, thank you.
Obi Rehan, ji sir. দুজন।
Khalid bhai, we want to see you every day.